So, good afternoon, everyone. I think we will make a start. Do apologise for the slight delay, but as you can see, there's a few people who haven't joined us yet. There's some horrific traffic issues, which is not particularly unusual at this moment in time. So, but I don't think we can wait any longer. So, welcome to Staffordshire County Council Oak Room and the Health and Wellbeing Board this afternoon. So for the record, I'm Mark Sutton. I'm the Cabinet Member for Children and Young People here in Staffordshire and also the Chairman of this board. So item 1, apologies please, Liam.
Thank you, Chair. I've received apologies from Claire McIver, Phil Pusey and Jill Heeson.
Excellent, thank you very much. And does any member of the board have any declarations of interest? Okay, I'll take that as a no then. Should all have had a copy of the previous minutes that have been circulated. I don't intend to go through it line by line, but if anyone has anything that they don't agree with or anything they would like to raise at another stage, please say so now. Otherwise, I will take that as a true and accurate record. Okay, thank you very much. And Liam, do we have any questions from the public at all?
None have been received, Chair. Thank you.
Okay, in which case then we will go on to item 2, which is Good Mental Health Priority Progress Update. And we have Jan Cartman-Frost and Nicola Bromwich here to present that. So good afternoon and over to yourselves.
Thank you, Chair. I'll just do a brief run through of the report. I'll hand over to Nicola Bromwich from the ICB. The Good Mental Health Strategy final approval was in March 2023 by the Council and the ICB, and the strategy has 6 main outcomes. Since then, we've been working on developing the action plan to support delivery of the strategy. In doing that, incorporated feedback that we received during engagement and additional feedback we received when we were drafting the plan. The challenge with the plan is the high level of transformation and activity that's taking place across mental health more widely. And so the plan is not intended to be exhaustive, but allows a range of actions to be monitored to enable us to track progress of improvement of mental health across Staffordshire. The main focus is adults, but in the engagement, one of the priority areas people identified was young adults and preparing for their move into adulthood, and therefore the strategy and the action plan recognises opportunities to improve mental health in adulthood when people are still younger. There's a link there to the Children and Young People's Mental Health Local Transformation Plan, which Nikki can take any questions on later on. We've also included an update on the wider areas of transformation activity that's occurring across the system. We've included in the report some examples of the metrics we've included in the action plan, partners that have contributed to the action plan, so it's developed between the Council and the ICB, Children's Services, Public Health, Adult Social Care and the NHS. The metrics we've agreed, we believe we can monitor, and we're starting to gather the baseline data to enable us to kind of report back on progress to Health and Wellbeing Board next year. You'll see in the plan that some actions have already started, so some of them were key actions that we wanted to include in the plan, and there will be some new ones in there that address gaps within the strategy that we haven't got actions for. And we've also included some future actions. There were areas where there was new emerging projects, but the metrics around that weren't quite clear. So in the end of the action plan, we've identified some future actions that I think people would expect to see in there. As you'd imagine, a whole range of partners will be involved in delivery of the action plan, and we're starting to do some of that work, initial discussions around some of the new areas. For example, we've got meetings starting in the new year with districts and borough around some of the housing actions. I don't know whether there's anything you want to say at this point, Nicola, or whether we want to take questions, Chair, first.
Okay, everyone's got the report and you've heard what's been said. Does anybody have any questions so far at all? No, that looks like... Oh, Julia.
Yes, thank you very much for this, and I've worked with you alongside you on this particular piece of work, and it is quite complex because there's a lot going on. There are two areas which are quite rightly highlighted in the action plan. One is people have access to services when needed and timely response to access, which totally support. But the metrics seem to be focused on monitoring the numbers of people accessing that service, which is good in a way, but one hopes that with all the work going on that eventually we'll start to see the numbers not increasing but levelling off, and hopefully if we manage to encourage communities for a healthier lifestyle, both physically and mentally, we may see those numbers tail off. What is important, I think, is the timeliness element. So how long does it take people to get access to those services? I know it's a real challenge at the moment, and it's not an easy one to sort, but I think in terms of the user perspective, that's the thing. It's irrelevant to them whether they're one of 5,000 people or one of 500. They want to know that they can get access to services as quickly as possible. Do you collect those metrics? And if so, can they be included in the monitoring of this?
We do collect those metrics. What we have tended to focus on within the action plan metrics is the NHSE mandated ones, which are, you're quite right, is about numbers and things like that. We do have, as a backdrop to that, a number of data collections. They're not actually published yet because it's still classed as experimental in terms of the information, but that is very much looking at waiting times. So obviously, part of our delivery of a number of these programmes will have different sort of waiting times allocated to it. So, for example, crisis response, we expect 4 hours to be the longest time that somebody would have to wait if they contact crisis. The ideal is 2 hours. For things like community mental health services, we're working towards that sort of 4-week wait, and obviously we're working towards that with children and young people's mental health services as well. What I would say is we've got quite a journey to go on, and obviously there's a number of component parts to how people access support for their mental health, and it's making sure that they can do that at the earliest possible chance. So things like the community mental health transformation, for example, may start off with a person presenting at the GP, at primary care. That may then be a direct appointment with one of the mental health R's roles, the mental health practitioner's roles, for some support. And if that then isn't being able to be met there, they may escalate into community mental health more formally. So it is quite a sort of difficult path to plot sometimes in terms of measuring the exact wait times, but it is something we're absolutely focused on looking at, because we do get feedback that people have to wait too long for services when they need them, and absolutely we want those people to access it at the earliest possible chance so that their needs don't escalate or deteriorate further and they have to hit our crisis services. So that is part of our planning, but hopefully we'll be able to share some of that data and information at a later date.
Just a quick one. So it's my understanding that the Good Mental Health Action Plan will feed in and be the action plan that is the bedrock of the Health and Wellbeing Board strategy. So I just wanted to make sure that was minuted really, so people were clear on that. In terms of the metrics conversation, it's probably worth a conversation. It's probably an action outside this meeting, but there are some metrics put together for the board, so we probably need to rationalise those based on that, so the board can be assured that we're getting progress on the mental health strategy. So just points of process really.
That's very helpful on that, and I appreciate the difficulties in actually sorting out what you're measuring and what it means. And in view of the programme that the Health and Wellbeing Board has, this strategy and its progress will come back in 12 months' time.
That's correct.
Is whether in 12 months' time you'll be in a position to have refined those metrics and include them, so that, because I think waiting, I avoided using waiting times. You know, hopefully we'll get to the point where people don't need to wait. Is actually whether that metrics could be included when we review progress in 12 months' time. And if you felt that was reasonable, if that could be,
Yep.
if I could propose that as an action.
Okay. Any further questions at this moment in time? Anything else to add yourselves at all? So can I just ask a question then in that case around increasing in school, expanding the mental health team, support teams in schools? I think I'm right in saying that I can't remember the term that was used when they were first introduced, but there's certain areas within the county that they were introduced. Is the idea then to have them covering every single school? And just a little bit of how that might work, if at all.
Thank you. Yeah, so trailblazer was the term, was the original term. So yeah, we were very fortunate that we were one of the few areas in the country to be one of the first trailblazers, and that was with 2 teams in North Staffordshire and 2 teams in Stoke-on-Trent. That was way back in 2018-19, I think now. So obviously what we have done as an ICB is pursued that quite rigorously. So the national ambition for mental health support teams originally for the end of this financial year was to have 25% coverage of all educational establishments in place. I'm really pleased to say, as an ICB, working very closely with our local authority partners, we have significantly exceeded that, so we're over 40% coverage at the moment, and we have a new team coming on board in January. We've also been managed to successfully secure 2 additional teams for the next financial year, so they will be starting in January 25, and that will be, we've prioritised that based on need and a number of different determinants around inequalities, etc., that children, young people and families experience. So we've targeted one of those in Stoke-on-Trent, but one of those in North Staffordshire again. So that will again further increase our coverage across the patch. Obviously, the mental health support team model is still in essence in pilot phase from a policy perspective. So obviously it's about evaluating that and looking at how that is embedding and working in reality with schools. But certainly, and obviously we're waiting for the new sort of iteration of the long-term plan to land. But I think mental health support teams in schools is very much going to be one of those things that will be rolled out, hopefully to every school, but I can't here and now guarantee that, but I can assure you that we're doing everything we can to make sure that we're expanding that support to children and young people as much as we can.
Okay, then, just to follow up a little bit, and then I take it that we're ensuring, and I know, and if Karen Coke was here, I could ask her that question about the local authority, but working together to make sure that we just not got similar things in some areas and then nothing in other areas. Because if some of the schools that we have got the Trailblazer team, whatever, they're not there, some of those areas may be where other services might need to do a little bit more, as opposed to everything being in one particular area. Are you happy that working together with the local authority?
Yeah, so we work really closely with Karen's team. So it's Becky Murphy that we've been working with closely in terms of looking at where the new teams will be sited. And obviously we also jointly commission the Action for Children support service with yourselves. And we've very much sort of got the agreement that where we don't have mental health support teams, schools in place, the Action for Children service is able to reach into those schools more effectively than the other ones, so that they're getting that additional support. Obviously, we know there's more mental health support teams in schools. Isn't the only answer to how we provide support for children and young people. So I think it's about looking at those range of different options as to how we can support. So one of the other things that we're about to do is actually put in an expression of interest for a partnership around neurodiversity in schools. So again, broadening that offer out to as many schools as we can. But yes, we work really closely with council colleagues around that.
Just for clarification and for the record, when you described the Trailblazer and you referred to teams in Stoke-on-Trent and Newcastle, the north part of the county, and then you said you've got some other teams coming on stream in 2025, and you mentioned Stoke-on-Trent, but you've got 40% coverage. I think certainly I would benefit from understanding the distribution throughout the county, because you know, there are areas like Cannock where there are fairly high levels of deprivation. And from what you said, it sounded it was all in the north of the county, which hopefully is not the case. But I think for the record, it would be really helpful, you know, if there is a map, you're showing roughly what the distribution is. Thank you.
I'm very happy to share with the board the analysis that we've done, which shows that coverage. So just for your assurance, we have 2 teams in North Staffordshire, 2 teams in East Staffordshire, 1 in Stafford and surrounds, 1 in Cannock Chase, 1 in Lichfield district area, 1 in Tamworth borough area, and the team that's coming on board is going to cover the South Staffs district patch and pick up a little bit more of Cannock Chase and so forth. Yeah, so we'll make sure you have that, and we're hopefully coming to scrutiny potentially in March to give a more detailed overview of mental health support teams in schools as a follow-up to when I came last time, but we're just agreeing that with the chair.
Nicola, thank you very much for that. So if there are no further questions, thank you very much. Thank you both. So this is where I do a little bit of rearranging of the agenda just a little bit. And so the next item we're going to take is item 7, which is right care, right person. And Lisa Cope from the police is going to introduce that. And obviously, and that follows on same sorts of themes as the previous item. So just so you understand where everyone is from, I've introduced myself. We'll just go around the room, and if I could ask members of the panel just to introduce themselves.
Yes, good afternoon. I'm Councillor Julia Jessel. I'm Cabinet Member for Adult Social Care and Public Health. It's health and care on my title, but it's surprising the members of the public who think that I have the NHS, which I don't have that privilege, thank goodness. Thank you.
Apologies. Chris Bird, I'm the Chief Transformation Officer for the Staffordshire and Stoke-on-Trent Integrated Care Board.
Hi, I'm Rachel Gallio. I'm Deputy Chief Medical Officer for the Integrated Care Board.
Good afternoon. I'm Neelam Bharadwaj. I'm Director of Children and Families for the Council.
Good afternoon. I'm Tim Clegg. I'm Chief Executive of Cannock Chase District Council and Stafford Borough Council, representing the District Chief Executives on the board. Thank you.
Gary Jones, Chief Executive, Support Staffordshire, Voluntary Sector, Umbrella Membership Body.
Emily McCormick, Chief Superintendent, County Commander.
Hi, I'm Ian Reid, Head of Prevention, Protection and Partnerships at Staffordshire Fire and Rescue Service.
Hello, Richard Harling, Director of Health and Care for the County Council.
John Topham, I pull this meeting together, and I also work in health and care at the County Council.
Hello, Liam Archer, Democracy and Governance Officer for the Council.
Thank you, yes. So, good afternoon. Just so I'll introduce myself first of all. So, thank you for inviting me to this board this afternoon, Chair. So, I'm Lisa Cope. My day job is Head of Force Contact at Staffordshire Police. I've been working in Force Contact for coming up for 34 years now. But I've got the pleasure of being seconded to our strategic change team back in Force, leading on the business lead for Right Care, Right Person for Staffordshire Police. So I'm just going to take you through a bit of a presentation about where we're at the moment and our approach in Staffordshire. And obviously I will take any questions at the end. I'm presuming it's that one to move forward the presentation. So the first slide just talks about the principles of Right Care, Right Person. So Right Care, Right Person is a model to ensure that we can better protect vulnerable members of our communities and provide them with the specialist help they need when they are making contact with Staffordshire Police. It's a four-phased approach, and I'll go on to describe the National Partnership Agreement a little bit later in the presentation. So phase one of Right Care, Right Person looks at, focuses on reports from partners and the public in relation to concerns for welfare and walkouts of acute healthcare facilities. It's we are aiming to launch on the 6th of February, and this is very much our efforts at the moment are concentrating on making sure we are in a good place to go live in February around phase one. Then the 3 further phases of Right Care, Right Person will be launched in May 24, which focuses on AWOLs and walkouts of mental health facilities. And then phase 3 in August 24 focuses on transportation. And the final phase, which will launch in November 24, focuses on Section 136 management and overall management of mental health incidents. So I just want to, throughout this presentation, I will focus on that the police will continue to respond to all incidents where there is an immediate, real and substantial threat to life or risk of serious and significant harm. So we'll be reviewing all incidents that come into the force on a case-by-case basis to assess that risk and harm and determine if the right care, right principles will be applied. So I'll just talk through the where we're at the moment in terms of the launch of Right Care, Right Person. So it launched officially in July of this year, and through a number of multi-stakeholder engagement events, and some of you around this table were at those events. We noted that implementation would be phased and very much a partnership approach with systems colleagues across all the integrated care framework. These events were very well attended by local authority, health and social care partners from across the framework, as well as third sector organisations. So we're continuing to be involved in that partnership approach. We are engaging a lot with the partnership framework across the ICF to update on Right Care, Right Person. And we most recently attended the Mental Health and Learning Disability and Autism Portfolio Day on the 6th of October, where community mental health transformation and portfolio strategic plans were obviously discussed in detail. And again, some colleagues were around the table at that day, albeit I lost my voice, so I couldn't present on the day. We've established a multi-agency partnership group with representatives from across local authorities, health and social care, the voluntary sector, to work through the implications of Right Care, Right Person and share the learning. And we've established a single point of contact for stakeholders to communicate issues or concerns regarding Right Care, Right Person. And at the final slide, I'll just talk through some of the detail around that. The partnership tactical group is multi-agency, and we're meeting monthly at the moment. Leading up to go live, we are going to put those meetings in weekly, and that will enable that really vital communication to just ensure that the policies and procedures and practices are discussed at that tactical and operational level. And this group will also undertake proportionate lessons learned, looking at scenarios, reviewing them and improving the quality of service, and addressing those cases on a case-by-case basis where there's any concerns that partners may have experienced. And then we'll feed that learning back into our control room, who are fundamentally at that first point of contact. They're crucial in those principles that I will describe in a moment. The Staffordshire Police Senior Responsible Officer is ACC Stuart Ellison, and he is leading the strategic principles of Right Care, Right Person, and focusing on obviously the activity of that tactical group to ensure that all the partners have that really robust and effective understanding of Right Care, Right Person and its impact and in aiding and informing the planning process of the further rollout. So this slide just describes the partnership landscape that's involved in those partner tactical task to finish meetings. So you will see there that all partners are represented from obviously the Wellbeing Board, Integrated Care Board, Fire Service, West Midlands Ambulance, City and County Council, local councils, health trusts and other partners. And the inner circle describes the activity that we talk through around facilitating. And I do want to say that these partnership tactical task to finish groups are very much Staffordshire Police facilitating the conversation, recognising that particularly the Integrated Care Board and the framework are crucial to making sure that we're applying these principles in the right way. So moving on to the next slide. So just want to spend a couple of moments, if I may, just talking about the National Partnership Agreement that was published nationally in July this year, which sets out the following actions, which I'll talk through for right care, right person and mental health. So this is a national agreement that was signed by the Home Office, the Department of Health and Social Care, the National Police Chiefs Council, NHS England, the Association of Police and Crime Commissioners and the College of Policing. So this is very much a joint multi-agency governance framework that has been developed to implement and monitor the right care, right person approach locally. And it's really recognising that those people with the lived experience of that urgent mental health pathway, including ethnic minorities, should form part of that governance structure. And for those of you that have had the opportunity to look through the Humberside approach, which was where the National Partnership Agreement and the subsequent toolkit was developed, that's very much recognising the lived experience of those that come into contact with the police and other agencies as well. It's absolutely about reaching a shared understanding, so it's a partnership approach around how we implement right care, right person locally, and the roles and responsibilities of each agency in responding to people with mental health needs and those in crisis. So it covers a broad spectrum of needs and includes agreeing what the remit of health services will look like around primary care and secondary and mental health services, local authority services as well. It enables that universal access to 24/7 advice, assessment and treatment from mental health professionals for the public. So really keen to see where in relation to the NHS 111 Mental Health Option 2, which I understand is being soft launched hopefully at the end of this year. Really, and again, some of those partnership tactical meetings, those sorts of discussions are being had. We're also putting in place a really good communication platform so that that advice, those communications are done through that partnership approach as well. Some of the other significant actions within the partnership agreement, and this isn't Staffordshire Police actions, this is the national toolkit, is putting in those places arrangements to work towards ending police involvement in situations where applying the right care, right person threshold isn't met. So this is ensuring that the initial response to people experiencing mental health crisis, responding to those concerns where you've got welfare needs with mental health needs, undertaking welfare checks where the person is already in contact with a mental health service and or another service commission to provide that mental health support. Putting in place arrangements for missing persons from mental health facilities and those that walk out from acute health facilities, including emergency departments and GP surgeries, and also the conveyancing in police vehicles. The next slide continues with these principles around this partnership approach to it within the framework. So it's embedding those multi-agency ways of working. So I'll just go into a couple of examples that we're doing in Staffordshire, or we're working towards in phase 3, which is August next year, in terms of commissioning, having mental health advisors working directly in our force control room alongside our colleagues in the control room. So this is where people that phone us in mental health crisis, particularly those that may be having suicidal ideation thoughts and are threatening themselves to commit harm, and we're struggling to locate those individuals. That can take our call handlers some time to establish where they are and locate them, and also provide those services to make sure that they don't come to any harm. By bringing in those mental health advisors into our control room, there's almost that soft launch of the transfer of that call and the caller won't be aware. We won't cut the call off because obviously we would lose that contact with that individual. But transferring that to those mental health advisors that can provide that real good support at the first point of contact. And then they potentially that would include your AMPs, your crisis teams that would be working alongside it. So we're really giving that one-stop approach to people that are calling us for mental health advice. And that, as a subsequence of that, it releases our staffing in the control room to be answering 999 calls where you've got people phoning in that are at risk as well. There's a couple of other approaches that we're looking at, working with our colleagues in the ambulance service around putting a tactical police advisor working alongside our colleagues in the ambulance service, so that when people are phoning us in crisis, we can signpost them to the right person as soon as possible to get that support. Again, talking through the next steps as well is ensuring that arrangements are in place to minimise those delays of handovers of care between the police and mental health services. Really interesting to talk about the presentation earlier around that. And currently we know that there are significant delays. We've got police officers waiting for up to 16 hours at times, waiting for that transfer into that mental health expertise. So this is the next phase is our approach in Staffordshire. How we'll do this is within those tactical meetings that we are holding monthly that will continue throughout the next 3 phases. Again, developing an approach for police and health systems to work together to quickly identify the best place to take a person detained under Section 136 of the Mental Health Act to reduce time spent on conveyance as well. Just moving on to the next slide. There's just a couple of more points on this. And this is about, I think I've gone one step ahead. So again, developing that local escalation protocols for situations involving significant systems delays that result in people being inappropriately under the care of the police when they should be accessing mental health support. So detentions in custody. So all areas should be ending the practice of detaining people with mental health needs in police cells, and recurring situations where health partners feel the right care, right person threshold is met, but a police response is not provided. So designing those protocols that should include information on how to escalate urgent issues that cannot be resolved locally. And then a couple more points, establishing effective mechanisms to support data collection and sharing. So within the toolkit, within the National Partnership Agreement, there is a benchmarking and evaluation guidance. So that isn't just about recognising how many concern for welfare incidents we are receiving as Staffordshire Police, but also recognising the time that officers are spending dealing with mental health patients, waiting for assessment, etc. And then we can share that with partners as well. And there's a couple of national approaches that we will look at through the integrated care framework to deliver a better approach for that reduction of time that is spent waiting for that transfer of services. So there's a really good database that we're building in Staffordshire that will include some of that partnership demand as well. That will go live in February alongside phase 1, and that information we'll be able to share at those tactical task to finish meetings as well. And again, the final point in the framework talks about developing that really multi-agency training to support decision-making and understanding of roles and responsibilities across the whole of the integrated care framework, concentrating on very much the Mental Health Act as well. So it's really, really important that obviously we understand from local authorities, our health and care partners, the current likelihood of being able to meet these 10 recommendations, and we can discuss that in partnership ahead of and throughout the phased approach of the initiative going live. So to help understand the current position of our health and social care partners against these recommendations, we've shared a temperature gauge, if you like, through a responsibilities matrix. So if I take you to the next slide. This has been shared with all those partners to go away and look at what's changing in Staffordshire Police, and then look at what risks and mitigation they need to put in place. So from that, they'll bring those back to the partnership tactical meetings, and we'll talk through those issues together. So to improve our understanding of that potential impact of the changes to policing, identify what's happening now, what will change and is there a gap, and then escalate to executive officers across the partnership around the solutions to resolve any issues. Transparency of roles and responsibilities as well. So those partnership tactical meetings are the perfect opportunity to all work together around the 4 phases of right care, right person, and it enables those difficult conversations which There will be, and there are being, but they're really good conversations, and using that as a guide. And then those identifications of any service gaps and changes required, we're escalating it to, obviously, the SRO, etc. And then, so just a final slide that just talks about lessons learned so far. So really important that we get the right representation at those right care, right person tactical meetings. And I'm assured that we have got the right people around the table. That will ensure that all organisations are represented at the right level at those tactical meetings, and that is really critical for positively moving forward. Making use of the briefing documentation provided, so to ensure that we've got a consistent message from the top right the way down to all service users and staff across all the services and agencies. We've got a single point of contact for right care, right person, so we've got a right care, right person email address that's been shared across the integrated care framework, where people can lifetime communicate concerns and queries, which provides a really consistent approach to that. And again, this is getting the messaging right, and I alluded to this on the first slide. This isn't about the police withdrawing from protecting vulnerable people. It's a national programme supported by the College of Policing, the National Police Justice Council, and the Department of Health and Social Care. So again, you know, it's really clear this isn't about the police withdrawing. And creating that feedback loop, so at those tactical meetings, we collect that information and then share that learning from that across the framework. And again, it enables us to share specific examples where partners may feel the wrong decision has been made, and these will be reviewed and that learning shared. And this is an initiative, it's a real learning process to ensure that we get it right. And then finally, investing in mental health services and lobbying for further funding. So a very much joint approach around those commissioning services so that we can go and invest in the right areas around potential growth and lobbying with partners around this table and the framework for that additional investment. And then the final slide just describes the key contacts in Staffordshire for you. So I've already said that the executive lead, the senior responsible officer is ACC Stuart Ellison. Then the strategic lead, so replacing Emily in her previous role, we've now got temporary Chief Superintendent Paul Talbot, and then myself as business lead, and then I have a project manager, Danny Hassel, and it just gives you the right care, right person email address there. If you want to feed any questions in through there as well, that's a further opportunity as well. So thank you, Chair.
Lisa, thank you very much for that. A few comments I'll make first, but before I do, I'd be interested, particularly from our health colleagues, as that's obviously a massive impact on your area of business. General thoughts and comments, but particularly whether you're happy with your involvement in the development of this so far.
Okay, so I think there's 3 points that I'd make. I think so. The first is to recognise that this is a significant change. It's a national programme, so not unique to Staffordshire, but it is our understanding that some other areas have perhaps adopted a shorter and sharper approach to implementation. So I think there is a recognition from health that colleagues in staff's police have been very proactive in terms of reaching out, and some of the examples were given by Lisa there in terms of away days. We've met with ACC Ellison, for example. We are active within the task and finish groups. I think we understand and support the principle of best use of scarce resource and getting the right support to the right people at the right time. That's, you know, as much of an NHS initiative as a police one. So I think we can understand that. But I think it's also true to say that there will be some operational challenges, and you know, I think Lisa, to be fair, has alluded to some of those in the presentation, particularly in terms of timeliness of response, the ability to hand over between different agencies. They're kind of typical flashpoints that you'd expect to see in interactions between any public sector agencies, and we certainly have those now with the police in the way that Lisa describes. So that we are, as I say, active within the task and finish groups. I think the next one's in January, I want to say, ahead of the first phase being implemented in February 2024. for, and I think we're also encouraged by the incremental rollout across the different phases, which gives us both an opportunity to work through the issues as and when they arise, but also evaluate the impact of each phase as each phase goes live. So I think we'd proceed with caution, as perhaps you'd expect me to say, but I think we recognise that colleagues in the police have been very proactive in terms of seeking to engage with us quite early in being able to implement the change.
Just pick up on one particular point, and that's about your feelings around capacity to be able going forward, and I think particularly about that long handovers for 136s and stuff along those lines. So, which I know from personal experience can sometimes take up an inordinate amount of resources of people just sitting around not doing an awful lot. So, any thoughts on that, Chris?
So I think one of the things we'd need to work through for the task and finish groups is around risk appetite, actually. So where we do have officers on a prolonged handover, have we got the risk appetite around that correct? And is that about the absence of a timely or comprehensive response from mental health colleagues, or is it about actually we've got that response there, but both agencies are perhaps adopting a little bit of a risk-averse approach in order to give the freedom to the police officers to exit the scene. So I think there's both a resourcing element to it, and you'd expect me to say that NHS resource is constrained, but I think there's a fundamental question about the risk appetite that we need to work through as part of those task and finish groups.
I wondered before I open it out to other people whether Richard, from an adult social care and social work aspect, you got any comments or questions that you'd like to?
I mean, similarly to Chris, so we recognise the opportunity of collectively using resources better, and do appreciate the approach of doing it gradually and engaging with partners. So whilst there are opportunities, there are risks, and the risk is that we end up with sort of unmanaged gaps appearing. So things that the police are doing now that end up not being done. Quite like the responsibility matrix, and I guess that of all the things that the police are doing now, they either fall into the category of actually don't really need to do that, in which case we just stop, or somebody else needs to do it, in which case an agency needs to put their hand up and say, well, that's mine then. I just had a question about governance. So all of that kind of needs to be signed off somewhere by all agencies at an appropriate level. I just wondered about your thoughts about where that happens.
So Emily might be able to help me out with this as well. So in terms of, we've met with, now their names elude me, ICB, can't think of his name. We've met with, the ACC has met with him, and I can't remember his name, I do apologise. And we've talked about governance. So as much as this is a partnership approach, this is what we're doing in Staffordshire in terms of that, but we're having those conversations with the chief execs from the ICB, etc., around that governance, so that tactical group, where there's any issues or concerns around that we're raising at that tactical level, they're taking to the appropriate exec in those within the integrated care framework. Around signing it off, because it's a national approach to it, it's very much, whilst Staffordshire Police are facilitating a lot of this, a lot of the solutions are health-led solutions, but the difference with this, in fact, in relation to your first comment, this isn't about the police not supporting. So if there's a supportive role in some of that demand activity, we will still continue to do that with our colleagues. But if it doesn't meet the threshold for right care, right person, where it doesn't sit within that concern for welfare, there's no immediate risk, then it will be over to whichever agency it is. We are finding that most of the people that are ringing us are already in contact with some form of service. They're just phoning the police because they don't know what to do, and they're unsure whether the police can help them. So again, around the overall governance of it, I think it's kind of a joint approach, isn't it, with the ACC and the Integrated Care Board?
Yeah, I think that's correct. I think it's, as Lisa said, it is being facilitated by policing and it's been driven nationally from, so the background to this is that this is something that Humberside started themselves, working with their partners. and just this year, really, it's been recognised. They had an HMIC report, and it was recognised nationally, and Police Chiefs Council, with the College of Policing, sort of made those arrangements with the government Home Office, really sort of took this on board in terms of something that this should be adopted nationally. So I think from a Staffordshire perspective, clearly we're working closely with partners at a tactical level, and then through Mr Ellison from a strategic perspective in terms of our phasing. But I think it's more of I don't think there will be a point at which we'll say, right, we're signing this off as everybody's agreeing to it. I think it's more of an iterative, phased approach in terms of where we will start to see some of those differences in terms of policing response, if that makes sense.
I think so. It's just whether there's an opportunity at a strategic level to get partners around the table and sort of cast an eye over what the tactical groups are proposing and say either yes, we're broadly comfortable with this, or no, there are significant risks that are emerging that we need to thrash out between us.
So though that first kind of strategic meeting has taken place, and I know that it was very encouraging to see that that will happen again. So there's an opportunity between now and go live for the ACC to reconvene that meeting to describe what you've just described. Yes, absolutely.
Chris, you, I think, want to come back on that particular point.
Yes, if I may. So Lisa was referencing a meeting between the ICB Chief Executive, so Peter Axford, I think is the name you're reaching for, and ACC Ellison, and indeed others. So I think part of the role of the ICB in working with the police is helping the police to navigate health governance systems. And the ICB is, of course, a body in and of its own right, but it's also a kind of collective noun to describe other partners in the system, and the ICB board does include partner representation from all of the NHS trusts within the system, so UHM, MPFT and North Staffs combined. So that might give us an opportunity for governance through the ICB board route, but I think the takeaway is part of our role in an ICB is to help you navigate the health system of governance, and so more than happy to have that conversation with you outside of here.
Sorry, I mean, just to recognise that the local authorities, both Stoke and ourselves, will have our own governance, so whilst we work with the ICB, it can't speak for us, if you see what I mean. So just a sense about how we sign that off.
If I may, Chair, so as part of the approach to our communication strategy. So I presented last week to the Stoke-on-Trent Children's Board. I was presenting to the Staffordshire one, but I think it's been postponed, which was due to be on the 18th. So again, this is we're taking ourselves out to as many of those boards as possible, just to describe what we're doing in Staffordshire and our approach around it. So hopefully, after attendance to those boards, people should be more informed about the impact on local authorities in particular.
Neelam?
So obviously I won't repeat the discussion we will be having at the Safeguarding Board, but just to say I'm aware that Clive Cartman-Frost is involved in the operational group looking at these matters. And really from children's perspective, we do give clear instructions to our own residential staff and providers as to what steps they need to take in relation to managing young people and their behaviours before they contact the police. So from our perspective, as we've talked so many times, the complexity of behaviours that we are now seeing in young people is pretty risky and dangerous, and they are in fact assaulting people left, right and centre, not only health staff but even police staff. So in those circumstances we do need some input and help, but we will continue to work with you. We appreciate the approach you're taking gradually and interacting, and we will see how it works, because we don't want any hard and fast rules because it's a new situation, but equally we are dealing with young people who can present a great deal of risk.
Thank you. I just wanted to focus on item 3 on the action plan, which is around 111. That seems a pretty critical kind of early intervention measure, which if that is done well, will stem a lot of this at source. And I'm sure many people in the room will have found themselves in that position of phoning 999 for a friend or relative out of hours because they literally don't know what else to do. So I just wondered whether or perhaps when we can hear a bit more about that new 111 mental health option. Remind me who the current provider is and what the kind of public rollout of that is, because that seems quite critical. Slightly concerned that that hasn't launched yet and you're only less than 2 months away from implementation.
Thanks, Gary. So as part of the long-term plan, obviously a key aspect of it is around parity of esteem between physical health and mental health, and national policy identified NHS 111 as one of those areas that needed that approach. So anybody that has called 111 will have had a certain experience, and it isn't necessarily, it doesn't necessarily support people with mental health needs as quickly as perhaps it should. So across Staffordshire and Stoke-on-Trent, we've been implementing a piece of work which is around the formal launch of NHS 111 option 2, which is called the mental health option, will be on April 1st. What we in Staffordshire and Stoke-on-Trent have done is obviously tried to front load some of that activity so we understand what the demand is that's coming across. So our current NHS 111 provider is Totally, or Vocare, people might have previously heard them as. Obviously there will be a regional change of that NHS 111 provider come April. But it is actually our local providers, MPFT and North Staff's Combined Healthcare, that have been resourced to deliver that NHS option, NHS 111 option 2 provision. So essentially, there's lots of technical detail behind it. I'm really happy to talk outside of this, but when somebody phones up, they'll be given that option 2 if it's mental health, and that will go straight to our mental health provider trusts, who will have access to those clinical patient records, so they'll know if it's a known service user and be able to respond more effectively to that provision. But it's very new, so it's very early days, and regionally we were ready to go, but actually we need to wait for our regional colleagues in UEC and urgent emergency care to do some of the technical work so we can actually get that message out. So we've got a big comms campaign, we're just holding fire on it till we can get that started.
Thank you. I guess my observation would be that people with mental health needs access a whole range of services, some of which you've talked around, in particular mental health services, adult social care, drug and alcohol services, because they have complex needs. And one of those services that obviously I'm more involved in is around housing options. And my observation would be that whenever there's a change in service provision from one of the providers, be that drug and alcohol or adult social care, it has an impact on all of the others. And we will see a difference in the way that people present to us and the difficulty they have in accepting and maintaining tenancies if that's the appropriate route that they go down. And so the final point on your lessons learned around investing in mental health services actually I think probably needs to be broader, and I think there needs to be a very clear dialogue between all of the service providers to understand the impact of each of those changes. Our housing options team, and I think this is common across the county, are under enormous pressure at the moment generally, and that makes it even harder for us to respond to people who've got very complex needs. So I don't know to what degree you're engaging with those services as part of this look, but I think what this change prompts is that in the importance of that exchange of information between all of the services that this client group access, so that we don't have unintended consequences. Thank you.
So there's an opportunity for any agency or voluntary sector or somewhere that we might have missed to join those tactical task to finish meetings. So if there's anybody that thinks there's a gap in attendance at those meetings, then by all means just send an email into the right care right person, and we'll make sure that they're on board with those meetings.
Just to offer some reassurance, really, this scheme, if you like, doesn't preclude the fact that we will continue with our local problem-solving partnership engagement at that level for some of the perhaps slower time cases where we all have to work in partnership in order to deal with things, particularly around housing and people with complex needs that need services and support around that. Where there's a crime element, antisocial behaviour element, we'll still continue to work in partnership in exactly the same way as we do, albeit taking account of the fact that some of this has more of an impact around crisis management than that longer term problem solving opportunity for all of us.
So, just wanted to allude to something that you mentioned previously. So you mentioned the national agreement. And picking up from what Richard said around the governance and sign-off or whatever, the one section of the document reads should be achieving the following. And the first one states agreeing a joint multi-agency governance structure for developing, implementing and then monitoring the RCRP approach locally. I wondered, picking up from the comments that Richard has said, whether we've actually got there or not, because it seems to me that perhaps we haven't.
Can certainly take those concerns back to the SRO, to Mr Ellison, and have those discussions with Stuart.
Yes, I mean, picking up on that particular point, I don't know the answer, but I will ask the question whether the Health and Wellbeing Board may be well positioned to be that governance body. It's already in place, already monitors key strategic aims within the county and Stoke-on-Trent. So I just wonder whether that may be a simpler solution than creating yet another body, which I always tend to try and avoid. I mean, I fully understand why this is being done. It is a matter of using resources in the most appropriate way. And, you know, welcome the partnership approach that's being done, and you've gone through that thoroughly. I'm going to be a little bit of an awkward so-and-so, which I can be from time to time, and come at it from the public's perspective. In many ways, those who are already engaged with mental health problems, who have a crisis, they should already have a contact, either a caseworker or an emergency number. But that doesn't apply to everybody. I know you made the point that majority of the people that you deal with mental health problems are already known to the services. But there are those who do go into crisis, who, you know, perhaps should have done, but aren't known to mental health services. And from the public's perspective, they will see this as it's something else the police are now not doing. I'm a local councillor, as my colleague is here, and I can assure you that, you know, a parish council at ground level, that's the perception. So I see all the work you're doing at a strategic partnership level. Changing the behaviours of the public is not an easy nut to crack, whether it's from public health perspective with what we try to do to get people to live healthier lifestyles, whether it's the NHS perspective, trying to stop people inappropriately going to A&E, which is in effect the principle that you're trying to stop. it's proving very, very difficult. If people, if you've got a friend or a relative that's in crisis, you don't know what to do, what do? You phone 999. And I think there's a lot of work, and unless you get the public to understand the right thing to do, when they get in touch with your call centre, they'll be coming to people like us and saying, this is just something else the police are washing their hands of. So I do raise that as a real issue. You've got to get the public on board, and they need to understand what they need to do. Because otherwise you'll get abuse and we'll get abuse. I'm afraid we live in that kind of society. But when people are under pressure and they don't know what to do, and somebody is trying to fob them off from a call centre, it'll be seen just as that. So I think there's some real, you need to start getting the messages out there, or otherwise it'll be misconstrued and it will backfire on you. I think the other thing is, you've mentioned, and this is just a particular instance, patients who go AWOL. How do you propose as an alternative to dealing with those kinds of people, some of whom, if they don't take the medications, can be a danger to themselves, dangerous to others, others may not? The police are the only organisation that I know that can actually pick somebody up, potentially against their will. Would you still be continuing to do that? If not, who else would do it? Because if you're going to say the ambulance service, I think you might have an issue there.
Just a couple of bits. I'll try and answer both concerns. So in terms of public perception, I do see where you're coming from. However, the public perception around police resourcing, I think it's about how we change the narrative, because by implementing this correctly, that will free up police time to deal with some of the other priorities, well, the key priorities of the public, which is around burglary, antisocial behaviour. You know, I could name a number of things that local people want to see us being more effective around. So it is about messaging, it is about communication. In terms of mental health crisis, we will never turn our back on somebody that is vulnerable and needs that support. This isn't about us saying we're going to wash our hands of people in crisis and who are vulnerable. But I think it's really important to recognise that the police aren't the right people to deal with people in mental health or physical crisis. As Lisa's already alluded to, we will still have a supportive role in some of that. And if ambulance colleagues, if mental health colleagues need the support that the police can provide within our powers, then we will continue to do that. What's really interesting, and it's a public-facing report, the most recent IOPC report around preventing deaths following police contact. One of the first points that they make in their opening to that report is that the vast majority of incidents where vulnerable people have died following police contact, the police should never have been involved in those incidents in the first place. They were incidents where other services should have been the responding agency, and they recognise that the police aren't the people with the right skills, experience to deal with people in physical or mental health crisis. So I think that's really important to recognise. In terms of AWOL, I think there's sometimes a misconception around the powers that we do have. We don't have powers to compel somebody to return to somewhere that they've left unless they are under a specific section. So if they're under a hospital section and they go AWOL, then there could be a role for the police in that. But if somebody just decides to walk out of an A&E department or out of a GP surgery and they have mental capacity, we have no powers to compel them and put them in a police car and take them anywhere. And that's again where the police shouldn't be utilising that sort of activity, because they don't have the power to do that. We do have specific powers under Section 136, and we will continue to utilise those powers. There's nothing within Right Care, Right Person that changes policing powers in terms of that. But it is really important that we get the messaging right, that we we aren't the right service to deal with certain circumstances. And coming all the way back to your first point, I think this is about having a conversation with the public about what they want to see their police service doing in terms of dealing with crime, dealing with antisocial behaviour, and then working with partners in order to meet some of the significant risks around vulnerability and mental ill health.
Okay, I think we've certainly given that a good go this afternoon. I think we'll draw that to a close. Having some thoughts about at what point it would be suitable for you to come back and be able to present on how perhaps the first stage has gone. Perhaps we can communicate over that what would be the best, and I'll liaise with Liam about the notes and some of the questions that have been asked, particularly around that governance thing, so that we can perhaps further discuss that outside of here, and then at a future Health and Wellbeing Board come back. So Lisa, thank you very much for your time, and Emily for your inputs as well. Okay, so we will go back up the agenda and we will do item 3, which is Staffordshire and Stoke-on-Trent Adult Safeguarding Partnership Board. John, more than welcome. John, are you going to be starting in due course? Or is one of your super colleagues?
Is this one to start? Yeah. That's right, I'm just getting my equipment. First of all, apologies for the late arrival. Like others, I suspect I've been caught in the traffic.
You were not,
yeah, okay. Thank you, and thank you for the opportunity of coming along and presenting the Safeguarding Annual Report to you. I know we only have 15 minutes on this agenda. I am joined with Helen Jones, who's the business manager, and Ruth Martin, who's the principal social worker. I should keep my input brief, Chair, to now opportunity for questions and comments. But I will make certain assumptions that the papers have been read, the cover paper and the annual report itself. If I make that assumption, it will keep my introduction brief. But I do want to emphasise that the annual report is a long document. It's 55 pages long. It's the longest document that we've actually produced as a safeguarding board, but it is deliberately long because it relates to adults with care and support needs who are at risk of or experiencing abuse or neglect, and that they need some protection. So that's the sort of focus of the Safeguarding Board. The annual report is demonstrating or illustrating the breadth of activity that's taking place to actually keep people safe, or in some cases actually respond when that need arises to protect them from harm. But where the report has grown this year compared to previous years is that the strategic plan was revised last year, and it was to introduce a new priority around effective practice. And I just want to make this point to you. I think we would all agree that we hear lots and lots about lessons that need to be learned. And I was watching the news only last night. In fact, if you listen to the COVID inquiry today, we talk a lot about lessons learned. I think we're actually good at identifying what those lessons are. I think where we have some challenges is being able to demonstrate that what we've done as a result of those lessons learned, because what we find is, and we've seen this from safeguarding, is that there are recurring themes. So the question is, how do we break the cycle? So the strategic plan has this priority around effective practice, which is essentially about identifying 5 recurring themes, and then for the Safeguarding Board to be seeking some assurances from amongst the connected partners, and we're approaching 30 partner organisations now. We want some assurances around the action that's taken to change practice so that we start to actually implement and put in place some of those lessons that need to be made. So that's why the report is bigger. It covers the spectrum of partner activity this time. And clearly there is more that needs to be done on that, but this is the first year of a 3-year strategic plan. Chair, I did say I'd keep it brief, and I do want to enable the opportunity of any comments or questions that might arise. And again, I'm sure that Ruth and Helen will be delighted to respond to any that is within their domain.
John, thank you very much. Thank you very much for that. Okay, so opportunity to open up to members of the board for any questions. There must be some. Richard.
So just a general one, John. It's a very comprehensive report, so thank you. Can you just give us a feel for, if there's one thing that you're really pleased about in terms of progress in the last year, what would that be? And if there's one trend or issue which is concerning you, what would that be?
Things that have caused pleasure. I think it would be fair to say that since the revision of the strategic plan, what I've described in previous annual reports as a maturing safeguarding partnership board, I think we've matured quite a lot. I think there's a much clearer focus on what it is that we're seeking to achieve. I'm sure that partners, and there's a couple in this room, would say that when we attain safeguarding boards, it's not a talking shop. We're actually focused on elements within the strategic plan, and we need to demonstrate that what we put in, these fine words that we write in documents, are being translated into action. I think, and the report reflects this, that there is quite a broad spectrum of activity that's taking place across the partners, working to a common and a coherent plan, and a willingness to actually engage and to be seen to be making a difference. And I think Helen would allude to some of the work that we do around prevention and engagement, where there's a lot of work which is going on. And we still need to do more, because there will still be parts of Staffordshire and indeed Stoke where people will say, we never even heard of the Safeguarding Board. But there's been an awful lot done to raise awareness, and I think that's reflected in the increase again in the number of safeguarding concerns. So that would be the thing I would be particularly proud of, the fact that we've got this good engagement. We have the meetings are very well attended. I heard the reference to the ambulance service. We do invite the ambulance service, but they never come along. They say we've got 28 safeguarding boards. But by and large, all our partners have got a very, very good attendance record. In terms of the areas for more work, and I have alluded to this with the priority, it's undoubtedly about how we demonstrate and evidence that we're actually making a difference as a result of what we've learned. And I'm sure Helen will allude to, and she might turn this into one of the things that she's pleased about. But from my perspective, I think we need to be getting practitioners along to engage in some of the events that we've put on. There's been over 1,200 people, 1,200 practitioners attended the learning that arose from one of the safeguarding adult reviews around Andrew. I think we need to be doing more of that. And until we start to see some of the actual changes in practice, I don't think we can rest. We need to keep on with that. And the other point I'll just add to it is that's made more challenging sometimes with organisational reorganisations taking place. We think we might have cracked it and we're on the right track, and then we find there's a reorganisation. Some of the people we've been working with are moving on to other roles, or we've maybe got additional responsibilities in the role, and it's a challenge then to just make sure that there's continuity involved in that. But let me just ask my colleagues on.
I'm really pleased about the strategic direction that John has led following the development day that many of you came to in June 2022. I think particularly the 5-point effective practice one, it means something to our practitioners. They understand what it is that they're contributing to. So I'm particularly in my role enjoying working with that structure. There are two things that I would want us to focus on going forward. So not one, there are two. One is I think we are challenged to better hear the adults that are being supported through the partnerships. And I think we're honest enough to say that. And the second thing is, and the data isn't with us completely yet, but it's a real challenge for us to better understand self-neglect. We've had our own challenges about understanding and encouraging others to understand what self-neglect is, whether or not it is a lifestyle choice. We're definitely of the view that it is not. And I noticed that in Staffordshire, only 2% of Section 42 concerns relate to self-neglect. Nationally, Professor Michael Preston-Shute is doing an academic piece of research, which I think he will publish in March, April, but the early heads up is that of safeguarding adult reviews, up to 75% of those have a self-neglect topic or theme. That there's a bit of a disparity there. So I think we want to wait for his piece of work and then understand what the response will be as a collective.
Not too much to add. I think Helen's covered most of the points that I would say. What I would just say, coming back to the point about learning lessons, is what's been quite heartening for me, following all the work that the board has done around the SAR concerning Andrew, is I've been asked to support workers on reviewing some more complex people that they've been working with, having recognised the complexities of Andrew. So actually these messages are getting out there through those training events, and being able to capture that and understand how that has then impacted positively on people's practice and recognition, particularly when we're working with some of the most complex people we do, I see as a real step forward for us within adult services. I would completely agree with Helen, though, however, that we need to recognise particularly self-neglect earlier than we do currently. Quite often we recognise that when people have already reached a crisis point. And so understanding how we can work more proactively and from a preventative perspective, alongside as well our public health colleagues, I think is an incredibly important part of the work that we need to do in the coming months, and something that I want to focus on with my social work practitioners going forward to help them to be able to recognise that. But I would also add to that, it is about the understanding of the need within our communities, the people who we actually don't often hear from, so the hard to hear, I don't know that I like that term, but it is a term that's banded around. But first and foremost, we need to understand currently the people that we hear from and why maybe we're not hearing from people. So it's about us as well, thinking about how we're reaching our communities, not expecting people just to come to us.
So follow up from that, can I ask a sort of practical sort of question really? I don't know whether a colleague from the ICB might be able to answer this. That self-neglect thing, those two figures that you rate are, you know, they're miles apart, aren't they? How much of self-neglect is potentially linked to people who then start to lose capacity? And I'm thinking dementia, Alzheimer's in particular.
Anything you miss?
Yeah, that's cool. So, from a statutory safeguarding perspective, when people lack capacity, we wouldn't actually class that as self-neglect under safeguarding. We would deal with that through our other legal frameworks, through things such as the Mental Capacity Act, and look at it under our normal adult social care pathways, through providing the right support, ensuring that they have the appropriate assessments and that we're responding effectively. Actually, a lot of self-neglect, just to give a bit of an overview, is for people who maybe have more multiple and complex needs, including things already alluded to in earlier conversations around such things as mental health, drug and alcohol use. A lot of times as well, that's related to things such as bereavement and loss, traumatic history. So some people who maybe don't access our services earlier on due to circumstances, etc. So we can be quite reliant on people having accessed alternative services to those within adult social care, because quite a lot of the time in those early stages, as I say, they wouldn't actually require the support of adult social care if we can support them earlier on in their journey. As well, though, what I would say is that if there are concerns about self-neglect that are identified, and one of the first things we would do is be establishing as to whether that person has got any concerns related to capacity. Have they got an undiagnosed dementia or other need that might mean we can support them in a better way? Thanks.
Thank you for that, Ruth. Julie, you have a question?
Can I first of all say, you know, it's a fascinating report because of the detail it goes into. And thank you and your team for compiling this. I always think this is like a check and balance. I see safeguarding from the other perspective, as Ruth knows, you know, the backlog that we've got, we manage it to the best we can, but the demands are ever increasing. And when you see the proportion of cases that are from people in their own homes, although accepting that that could be a residential care home, it's quite concerning. And what does always concern me is the pressures from the volumes coming through, and I can only see that increasing. And particularly with a previous agenda item we've had of right care, right place, you know, is that going to generate more cases that are going to get referred for safeguarding? Is how we can be reassured, hopefully, that actually we aren't going to miss those cases that really require a Section 42. Because if you get such large volumes through and you have a capacity, once you reach that critical mass there is that risk. And I think, thank you, Ruth, for your response in terms of, you know, we identify the lessons to be learned, but can we demonstrate we've learned them? I think that's a very good point. But it is the pressures that are in the system that I have always got that concern that actually becomes a bit overwhelming, and the risk is we miss a case.
I wonder if it's possible to make a couple of observations and then ask a question, if that's okay. So observation one is I think John rightly references the fact that there has been an NHS reorganisation. That's self-evident. I would, though, point out that the CCG, so Clinical Commissioning Group Director of Nursing, is also the ICB's Director of Nursing, and the safeguarding team that are housed in that function have hopefully offered a point of continuity throughout that organisational restructure. And the second point I'd make is to your point, Chair, about kind of essentially how well are we able to spot those early signs of self-neglect. And I think there, as a general observation, it's probably true that most health services are set up on a kind of medicalised model of care where we treat conditions and we treat illness, but the whole point of the ICB with its four kind of main aims is to shift towards integration and using population health data to integrate services that are wrapped around the patient rather than treating an illness. And I think that there's obviously a way to go in terms of that, but that direction of travel, the emphasis on prevention, early intervention, I think will help in that regard. Focus on wider determinants, focus on things like social prescribing, which probably hasn't got the level of prevalence it perhaps should have in NHS circles. I think will be important features of that conversation. The question I had, if I may, was throughout the report there seems to be a reasonable degree of consistency, I guess for want of a better word, between Stoke and Staffordshire in terms of the types of abuse, the location of abuse. What I didn't get a sense, I guess, was how that compares to national trends. So helpful to see the correlation between Staffordshire and Stoke. Is there anything within Staffordshire and Stoke that's different from what you'd see if you took a broader lens perspective as well?
Ruth, while you think about that, I might just react to Chris's comment. Can I just say, I know I did glance towards you when I mentioned organisational restructures, but ICBs are not alone, I can assure you, of all the partner organisations around the table. But I do think it's Councillor Jess has said, I think it very much gets to the heart of the pressures that are, in addition to the volumes, it's also the differences in the ways of working that practitioners are having to come to terms with. So I do acknowledge those points, and that is very well recognised amongst safeguarding partners. But Ruth, are you just able to offer some sort of perspective comparison?
I can always offer a perspective. A comparison to our national data. So Staffordshire and Stoke-on-Trent, from the points of view of types of abuse, location of abuse, broadly similar. There are some anomalies with things such as organisational abuse, which might appear to be more apparent in other areas. What we've been able to establish is some of this is down to how people record as to whether something is organisational or neglect. But broadly, we're very similar across the country. If you look at safeguarding data nationally, there are sort of two schools of thought as well. So you can see almost a 50-50 split across the country and at what point people are identifying something as being a Section 42 inquiry as opposed to a concern. That may even out with the incoming or just recently started CQC enhanced assurance process. We might tend to find that we get a bit more regularity of recording there, but we haven't been successful yet across the country, and that has remained the same. However, what we do know is that people's responses are broadly similar. So when you look at the information and the level of response local authorities are giving, it's broadly similar. We just may be recording at what point we've made a Section 42 decision at a slightly different point. And to be fair, the statutory guidance is grey, so in the beautiful way only government guidance can be, but I like to use that to make sure that we can give the adults our best response. I want to come back actually to Councillor Jessel's comment around volumes as well, if that's okay. Really to offer some assurance, I hope, around the fact that we have recently made some changes, and appropriate changes to how we are managing our incoming concerns, and also how we're utilising the resource we have to be more effective. So whilst those of you who will have heard me speak previously will know we did at one point have quite a number of pieces of work in progress that may have meant that responses were not as timely as we would have liked. That has now significantly improved as I sit here today, with the majority of cases being done within a 2-week period. So, and looked at. Everything is obviously looked at on the day it's received. But what we're also doing in the background is working very closely with our quality assurance teams and also with our providers to give them better access to information, to be able to make better decisions about when to refer into us. We're also working with other teams and other areas to make sure when referrals are made to us or when concerns are raised, that actually that is the most appropriate route. So we are looking at, making sure that we've got better use of the resource. We're also looking at some technology changes, including online referral forms that are going to help us better be able to more timely give us the ability to give a more timely response and a more proportionate response to what we've currently got.
Okay, thank you for that. Neelam, you have a question, and I think if we can make this the
Gary's indicated.
Gary, okay. I'm just wary of time, and I don't want to run out of time, although we did start 10 minutes late. So, Neelam.
Looking at the gender and ethnicity breakdown, which is, it's saying on my pack, page 35, where females seems to be quite disproportionately high featuring in stats. And I just wondered, you know, what the possible explanation is. Is it still that societal norms, what's going on there? And similarly, ethnicity, are we not finding people, picking up people, or what's going on there, please? Thank you.
You're absolutely right to sort of pick up on these two, and it does, certainly from the gender perspective, does give us a slight anomaly. However, we do know across the country that females are more likely to be at risk of abuse in their older age, and unfortunately that, you know, that could be because women live longer and are more likely to live on their own as well. But we are reviewing or ensuring that we're doing further auditing to look at what that is. With regards to ethnicity, as I alluded to earlier, one of my main concerns is that I'm aware that we're not necessarily hearing from some of our communities within Staffordshire, and that there is more work that we need to be done. Historically, we've actually had a bigger problem with with not having accurate recording in our systems, where actually we had a lot of unknowns being recorded. And actually we have bridged that gap somewhat by ensuring that our practitioners are being encouraged more effectively to appropriately record that data. However, there is still further work we need to do to understand and to do comparators with our local communities and what we would be expecting to hear, to make sure that actually we are hearing from people, which at this moment in time, as I said earlier, I'm not convinced we necessarily are reaching some of our communities, which we absolutely need to do more work around.
Chair, can I just very quickly comment? I know you want to move on. But there is an item on the January Safeguarding Adults Board which is picking up the very issue about abuse that may be hidden. And some of that will undoubtedly cover off, as we regularly visit this topic, about how we engage with people who seem not to be engaging from the data that's available to us. But January, hopefully we'll have more to report in next year's annual report.
Thank you. I'm a member of the Safeguarding Board, and I've been for I think about 7 or 8 years now. I have to say, of all the partnerships I go to, and voluntary sector tend to have to be a bit of a jack of all trades, so I go to lots and varied partnerships. I think it is probably the space in which I think those around the table, and it is a very big table with a lot of people around it, are probably most open and receptive to constructive challenge. People don't get defensive, they are really supportive but constructively challenge one another. I wanted to pick up on I think the one thing I would probably say that probably frustrates me the most in that setting, although there are fewer of them, I can guarantee you the 4 words that will be on pretty much every large-scale inquiry: poor leadership and management. And whilst quality and assurance team, again, I think has done, you know, great strides in the last several years to improve that and spot it earlier and try and get underneath it, I always feel that we're never really addressing something that feels kind of fundamental and structural about kind of residential and nursing care, where poor leadership and management just comes up all the time, repeatedly, and it always feels like it's a little bit beyond the remit of the Safeguarding Board. So if there was something I would kind of flag here, it would be, is there something more fundamental about why does that come up all the time? And if it can't be dealt with at the Safeguarding Board, is there somewhere else it should be looked at? Thank you.
Chair, I'll just comment briefly, and I just want to bring Griffin. I just want to make the point that Gary has made the comment today that he's made at previous Safeguarding Boards, and I thank you for that, Gary, because we do need, we don't get an answer to it fully, and it's back to my issue I mentioned earlier about recurring themes. You know, what is it that we need to do to try and unpick some of what is going on that's leading to those consistent findings about poor management and leadership? But Ruth has responded in the past, and no doubt, Ruth, you can respond now.
So only this morning I actually met with colleagues from the ICB and from Stoke-on-Trent as well to discuss the very issue of recurring themes within LSEs. And actually the main point that we discussed there, shockingly, was around the poor leadership and that poor leadership or change in leadership, change in management within these homes continues to be a problem. What we can see is that certainly, and I'll speak more specifically for Staffordshire, and that's of no disrespect to my Stoke-on-Trent colleagues, is that in Staffordshire we have provided quite a high amount of training into providers around this area. So in our next meeting, we will be calling on CQC to come to speak to us about their role and responsibility of ensuring that actually managers, registered managers within care providers, and actually what their role and responsibility is there. For me, this isn't something that as local authorities we on our own can sit and make those effective changes. We can raise those concerns, but there are other organisations, I think, who actually have a role in this, and particularly CQC, as they are the people who register the managers and who then regulate that service. So we're going to bring them into that conversation, and I would make it really clear that this conversation originated from the board as a question that came out of a board, I think it was earlier on this year or back end of the previous year. So we do make sure that we constantly trying to follow these things up to look to see as to whether there are other things we need to be doing to respond more effectively. And I'd completely agree. I don't think it's something at board level we necessarily are going to be able to solve. Some of these are more national issues as well. And I think I could speak here around the broader concerns about recruitment and retention in our wider care sector as well. Thank you.
Ruth, thank you very much for that that response. I think the two recommendations that were for this board today have been covered, and so thank you very much for the presentation. Before we finish, I understand that John, are you finishing with the safeguarding board soon?
8 years, it's flown by. It's always been along to the Health and Wellbeing Board. Oh right, thank you. Yeah, it's always been a pleasure to come along to the Health and Wellbeing Board. It's a really important part of the process, as Councillor Jess has alluded to, that there is some check and balance in the system. We certainly are not complacent as safeguarding partners, and every year, I think Alan would allude to, we take something away from the scrutiny processes and we do something to enhance the annual report, which again, it contributes in part to the increase in the size of the document, and I'm grateful for the positive comment on it, because it is actually a labour of love, but I think it's an important part of what we do. So thank you.
John, and so on behalf of this board, can I thank you, and personally as well, for what you've done for the Staffordshire and Stoke-on-Trent Adult Safeguarding Partnership Board, and also previous to, well, not previous to that, at the same time at one stage, the Staffordshire Safeguarding Children's Board as well. Thank you very much indeed. I'm sure all members around here would share the same feelings as well.
I think it would be one of the, I would echo Gary's point, it's undoubtedly, I've been involved in partnership working for many, many years, but undoubtedly this has been the one that's given me the greatest pleasure to be, and privilege to be part of, actually, but I'll leave it there, Chair, because you...
So we'll move swiftly on to item 5, Staffordshire Health and Wellbeing Board Audit Report, review of the terms of reference. John?
I'm aware that this is quite dry after the previous item, and I'm also aware of time, so I'll try and be reasonably quick. Between the last board and this board, there was a piece of work done internally around from our internal audit team, which was looking at the issues around the board and the processes really of the board. The audit paper hasn't been circulated with the board papers, but if anyone has a burning desire to see it, we can send it on to you individually. What we did do is, what I did do was in the cover sheet put the key recommendations that came out of that, because that was kind of the meat of the report, I suppose. If I was kind of rounding it all up and kind of like summarising what the recommendations were, they were twofold. One was around we need to update the terms of reference of the board. And the other one was, within those terms of reference, we just need to clarify a few processes and purpose and functions of the board alongside that. And that actually was in light of, also in light of recent guidance, which was ICB and Health and Wellbeing Board guidance that came from NHS, I can't remember what they call it, NHS Department of Health and Social Services, Social Security, last year in November. Which was guidance about how integrated care boards and health and wellbeing board work together as well. So it was trying to wrap that up as well. I think it's fair to say, looking back on the previous terms of reference, which after today will change hopefully, but are currently still on the website for the Health and Wellbeing Board. The previous ones probably weren't as precise as they could be. And probably the greatest challenge for us was to make sure that the board could assure itself that what was in the terms of reference were being met, that we were achieving what was in the terms of reference. So the new terms of reference hopefully do allow us to do that. So what does remain in the terms of reference are that we have statutory functions that this board must do, things it must do, which centre really around producing a health and wellbeing board strategy, and prior to that, and that builds on the joint strategic needs assessment as well. So those are kind of like the fundamental things that the board should do. Those are in the terms of reference, obviously, the statutory, and we have to do them. But there are also some things in the terms of reference that really pull straight from the guidance that came out last year around purpose and function and around the relationship with the ICB as well. And those are, and we'll cover some of those in a minute because I know Chris will talk to some of those in a sec, but they really allude to things, essentially the old commissioning intentions that CCGs used to do are now translated across the ICB. They've just got different names, I suspect. Chris will correct me if I'm wrong on that. But so things like the Joint Forward Plan, the annual report, and there's some other things around capacity plans for trusts and things like that as well. So I'm sure Chris can pick up on that. You'll be more well versed than I. So all of that is now reflected in the terms of reference and the forward plan within the terms of reference. And the forward plan essentially forms the meat of the forward agendas for the board. So what you see in the forward plan will essentially form the agendas moving forward for the board over the year. The other things that I just raised within that, there were some processy kind of things in there around membership and quoracy of the board. So one of the issues that we picked up because of the audit actually was that we weren't actually quora in June, which is why we've got to do a piece of work in the next item just to go back to what was agreed around the Joint Forward Plan last time and just reaffirm that. But also to also recognise that membership wasn't always, full membership wasn't always there. Quoracy arrangements need to be agreed. So quoracy arrangements are 25%. People have to attend in person. Sorry, that's kind of like statutory. It's not my rules. People need to attend in person. And 25%, if 25% is a half number, we'll round it up rather than down. The publication of agendas and papers is written in there, and we will adhere to that rigorously now and make sure that's kind of met. I think on attendance, one of the things that was raised was around attendance and membership. So there is a question in the paper around membership and whether we got that right. There is also, I'm proposing that we do a attendance register on an annual basis so people know what the attendance has been like from various members of the board, and if there are issues around membership, we can then make arrangements to tweak and change that if some sectors or some individuals can't make it for whatever reason. So we can have a look at the membership on a reasonably regular basis. And I think the other thing that came out of that was having a clear process for managing actions that come out of the board. There's been one or two today. So we will, from this point on, and the next minutes will include them, there will be an action tracker that will track actions that are agreed at the board that we can then keep on top of. So we will make sure that's brought in as well. There's a series of questions up at the end. I don't propose to go through this. I don't think we've got time. But I think the fundamental question are people happy with the revised terms of reference? Have we missed anything? Are there any issues around some of the chorus issues? Are our ICB colleagues happy with what's in there as well? Because it implicates you guys too. The one other one I would raise is around formal subgroups. There was a question that audit raised about subgroups reporting into the board and having cited papers before they come to the board. Now, we've never really formally constituted subgroups for the board, I don't think. So there is a question that floats around that about do we want to? Or do we want to keep with the current system, which is more of an informal arrangement where a lead officer comes to report on progress for particular issues? And the obvious issues are the priority issues for the board, which are the ones that's in the strategy, mental health, obesity, et cetera, et cetera. So I think I'll leave it there. I won't carry on that conversation, but that's it. I'll take comments from around the table.
So comments or questions, particularly around those revised terms of reference and whether people are satisfied with it. And I think I'll take happy with those, and I'll take it if people don't make comment that they are satisfied with those, and in particular the points that John raised. Is the board happy with the chorusy arrangements and the attendance and the register, and that we continue to do our business from the forward plan to do forward genders. So happy for any comments or questions.
I'm happy with the suggestion in terms of chorusy and things like that. I notice under discussion points, is the board happy to consider alignment with the Stoke Health and Wellbeing Board? I think, I'll be perfectly honest, I'm not sure exactly what theirs are, so what the consequences would be. I think one of the things I'm very conscious of, and Tim raised the issue of districts and boroughs and their housing function, is actually whether we need to consider broadening the membership to include other districts and boroughs, and whether that's through elected member or officers. I'm very conscious, as John and Claire will know, hello Claire, Richard will know, is through the public health function. We are working with local authorities, particularly in terms of their planning functions, to introduce health in all policies, so that, you know, when there's large-scale housing development, there is a health impact assessment. Will have a longer-term impact, but I think it's really important piece of work. And I just wonder whether reviewing our membership approach would actually be beneficial in that respect, because some of the functions that districts and boroughs perform are very important to how we deliver and how we shape the services. Tim has been, his attendance has been exemplary, but that is by exception, I think, with other members. So I just wonder whether, you know, before we finally sign off the terms of reference, whether we actually should allow a little bit of time, get feedback from members as to what do they believe that it's worthwhile opening up that membership. I know it's always said the most effective committees are a membership of no more than 6, but I think we do have a responsibility of making sure that we get the right people round the table, and that's just one point I would like to raise, Chairman.
Yeah, Julie, I would generally support that. I think a lot of the prevention and things that we deal with, and those determinants of health, very much depend on that place approach, and districts and boroughs have a absolutely fundamental part to play in that. You know, licensing, housing, and you know they know their place better than probably a large county council does. So I do think we perhaps need to do a little bit of work and have some thoughts about that aspect of the actual makeup of the board in that aspect. But certainly other than other than that, I think the terms of reference are about right, but happy to take comments and thoughts. Okay, of which there isn't. In that case, then, I will take it. Oh, Chris.
Sorry, Chair, just a couple of points, if I may. Rachel and I were just comparing notes. So just in terms of the membership, recognising that it's from the ICB, it's chair or non-exec and chief exec or director. So I guess Rachel and I, neither of those. So we'll just need to figure that through, I guess. But we are the nominated representatives onto the ICB from the ICB. So I guess technically we are the substitute members for those two, which is fine. I think John posed the question about whether ICB colleagues are content with the terms of reference. I've not spoke to Rachel, but certainly looking at the terms of reference, I think we are, and we recognise that we as an ICB have got particular responsibilities, and indeed the agenda item we've got later on, I think, kind of plays to that. The only thing I'd ask, if it's okay, and this is probably more a practical point, is that beyond the joint forward planning and the alignment of health and wellbeing strategies, I know that we've got additional responsibilities in terms of, say, joint capital resources plan. It would be helpful for us if we could align our forward plan business cycles so that we're not producing something specific for the Health and Wellbeing Board outside of the cycle of business for the ICB. So just helping us to kind of smooth that demand curve as it were. But hopefully hopefully that'll be okay.
I did reach out to Debbie, I did reach out to Debbie Danner about that. But if you want to advise on that, we can adapt the forward plan to make sure it makes those times, because it makes absolute sense. With the board's approval, we can also make sure that it refers your titles rather than the chief exec as well on the terms of reference. So we can do that.
Okay, thank you very much. I think we're all agreed on that, and those terms of reference, and we'll take forward the district representation, and certainly welcome representation from anybody here. So let's move on to the next item then, which is the item 6, which is the ICB joint forward plan, which I think I'm right in saying we've had in detail here, but it was that June meeting where we weren't quorate, so we do need to ratify that again. But we have had a detailed presentation previously. So, Chris, anything you need to add?
I think we have, Chair, submitted a presentation today as well. I think if that could be on screen, is that okay? Thank you. So I'm mindful of time, and as you say, Chair, we have presented the joint forward plan to you in detail. So this is a very short presentation. It's about 9 slides. It's a presentation in 2 halves, essentially. One is the kind of reflective piece on the current joint forward plan, and then probably more importantly, laying the ground for what needs to happen over the next few months as we refresh that forward plan, notwithstanding the fact that the ink is barely dry on the one we just published recently. So let's say the first half of the presentation just offers a bit of a reflective piece. So as you say, Chair, we did include or we secured the support of the Health and Wellbeing Board on the 8th of June for inclusion of the Statement of Opinion in the JFP that was published on the 30th of June. And we are statutorily required to annually refresh the JFP, notwithstanding the fact it's a 5-year document. Just in terms of context, the JFP is one of 3 planning documents that the ICB is required to coordinate. So the ICP strategy, which sets out strategic objectives across the ICP, so the Integrated Care Partnership, the Joint Forward Plan, so how the ICB and its partners will deliver those ambitions, and then a 1-year operational plan, which, as you'd expect, is a much more granular KPI and metric-driven document. The JFP doesn't duplicate the detailed strategies, but it obviously does sit within a context of lots of detailed strategies and partners' plans. So we have to take care just to get the balance right. There is a requirement from NHS England for each JFP to play out certain elements. So that does in and of itself add a degree of length into the document. So I think the JFP topped out about 100 pages or so, I think. And some of that just is about reflecting back to NHS England some of the content that they want to see, as well as then offering more value at local level. I won't dwell on this slide because I've kind of covered it off. The bit that I would draw attention to, though, just on the right-hand side, is that is our feedback from our population. So as we published the JFP in June 2023, we also launched a survey, online survey, which we've had quite a good response to, actually, and we'll be taking the output from that survey into the refresh process. This is quite a busy slide, which is probably difficult to read, but it's our attempt at being able to consolidate how the JFP links into each of the health and wellbeing strategies for the health and wellbeing boards in Stoke and Staffordshire, has the ICP strategies at its heart, and then sets out the kind of delivery mechanisms through the portfolios, which are a construct local to Staffordshire and Stoke-on-Trent, and you can see are grouped around particular themes, so population health, elective care, cancer, etc. In terms of the approach to the refresh, we don't have any national guidance as yet, so there is a degree of local determination. We are mindful, as I say, that we've published a 100-page document in the past 6 months or so. So our thinking at the moment is that this is the refresh is much more likely to be a companion piece rather than a restatement. But it will have a number of feeds in from local level and national level. And there's an item elsewhere on today's agenda about the JSNA refresh. So that'll be a key document that we'll use as part of that refresh process. In terms of the process, I draw particular attention to the box on the at the bottom of the green section there, in terms of working with local authority leads. So we predominantly work with Richard and his team, and then obviously partner boards and committees in terms of the health and wellbeing board. So I won't go through all the detail there, but just to recognise that we kind of explicitly acknowledge the need to work in partnership with local authority and health and wellbeing board colleagues. Suggested areas for refresh, so this is something colleagues can reflect on and send thoughts back to us on. There's quite a long list there. I'll just pick out 4 in particular. So the first is just reflecting any changes to local authority priorities. You're obviously going into a new financial year as a local authority. The JSNA refresh will give us some new content to reflect on as well, I'm sure. Long-term finance strategy and recovery, and I say that particularly because Richard is very helpfully leading for us at system level a programme around care homes, and we'd obviously want to reflect that within the JFP. The impact of ICS-wide strategies published since June, and we've worked quite a lot with Richard and Neelam's team actually in terms of developing joint approaches to both adult social care and children's services. And then wider strategic system development to reflect new areas of focus. And here I draw particular attention to the neighbourhood concept, which is something that we're continuing to develop, but it will take us beyond working at place level and help us to really refine our approach to understanding those wider determinants of health. And we're working in particular with Simon Fletcher at Lichfield District Council around augmenting the social progress index that they've developed there. But we're also going to take the concept through the improving population health board, which I think is one of the hats that Tim wears outside of his day job, again to make that connection back to districts and boroughs. And then just finally, next steps, the process that we'll work through as I've outlined, and then all being well, we will bring the refreshed version to the meeting of this group on the 7th of March, and hopefully on the back of that secure the statement of support for the refreshed document. So as I said, quite a short presentation, but happy to take any questions and comments on the back of it, Chair.
Thank you very much for that. Opportunity for any questions or comments at all from any members? Okay, I'll take that as a no. So the recommendations for the board are there in the document. I don't intend to read them all out. They are clear there for people to see, and they're in the public record, A to F. So I need to know, though, from the board that we are happy with that and those recommendations. So I'll take it that's a yes unless anybody indicates to the contrary. Okay, so those recommendations are approved. Chris, thank you very much for that. We'll move swiftly on to the last item, John, and that's the forward plan.
As I said earlier,
we don't do.
Sorry.
Yeah, okay, I'll just point that. There is an item on the agenda, the Joint Strategic Needs Assessment update, but that's being deferred to the next meeting.
Thank you very much for that, Chairman. I did have a meeting with Emma last week, and one question I would ask, or I asked, and I think the Health and Wellbeing Board would benefit from having a response when this is brought, is there is the Staffordshire Observatory. Is that still, you know, I've got an icon on my desktop for accessing public health data. Is that still going to be maintained, or will the new approach to the JSNA overtake that and then the Staffordshire Observatory cease?
The JSNAs are usually published on the web, on the observatory site, as you rightly point out. I think probably the web pages that we've got as well need a refresh, and it needs to be front and foremost there as well with a strategy. So we can do that. Yeah. Shall I carry on? Yeah. So this is quite easy. The forward plans in the terms of reference, it kind of summarises the things that are on there, and I'll just recap. Next time, the strategy priority is healthy ageing and frailty. So it's a progress update on that. The Staffordshire Better Care Fund is on there. Health Watch are on there. BAS and the joint forward plan. I always get that wrong. I always think of the Joseph Rowntree Foundation for some reason. So I don't know why, but anyway. The JFP and also the JSNA has been deferred from this meeting, but will come to the next one. Although at the moment, I think Emma's not here, so we'll have to negotiate with Claire or someone to cover for that.
Okay, any thoughts, comments on the future plan? We'll have to work on the right care, right person as well when we get that fitted in for an update, but we can just discuss that outside the meeting. Okay, so ladies and gentlemen, thank you very much for your attendance this afternoon. And if we'd started on time, we'd have probably only gone over by 1 minute and spent the 11. Take this opportunity to wish everybody a Merry Christmas and a Happy New Year, and we'll see you in the new year, those that I don't see before.